Good afternoon, everybody. Welcome. We're going to go ahead and get started. It's truly my pleasure today to welcome you to today's Grand Rounds and to introduce Dr. Elizabeth Miller, a scholar, a pediatric clinician, and a leader whose work has shaped how we think about adolescent health, violence prevention, and trauma-informed care. Dr. Miller is the Distinguished Professor of Pediatrics, Public Health, and Clinical and Translational Science at the University of Pittsburgh, the Edmund R. McCluskey Chair in Pediatric Medical Education, and the Director of the Division of Adolescent and Young Adult Medicine. She also serves as the Medical Director of Community and Population Health at University of Pittsburgh Medical Center Children's Hospital. Her career reflects a deep commitment to bridging rigorous research with real-world, community-centered change. What stands out most in Dr. Miller's work and what resonates so strongly with the theme of her talk today is her holistic approach to trauma-informed violence prevention. With training in internal medicine, pediatric, and medical anthropology, she brings an understanding that trauma is lived in bodies, in families, in communities, and within systems. And to me, this reflects a core truth in public health, that we cannot stay on the sidelines of harm, trauma, and inequity and expect to create meaningful change. Our work demands that we engage with the systems, environments, and conditions that shape people's lives, especially when those conditions perpetuate risk and vulnerability. Dr. Miller has never stayed on the sidelines. She engages directly with the communities to understand the realities of interpersonal and gender-based violence, and she works alongside youth, families, and local partners to design prevention efforts that are responsive, equitable, and grounded in lived experience. Through her community-engaged research, including her leadership on the Pittsburgh study, she models what it looks like to collaborate with humility and to treat youth and community members as essential partners in building solutions. Her work shows us that trauma-informed violence prevention is not just about interventions. It's about relationships, belonging, and the willingness to keep showing up for the community, even when it's hard. Today, she invites us into that same kind of courageous reflection. How do we build systems that prevent rather than perpetuate harm? How do we create healing pathways when trauma has already occurred? And how do we honor the lived experiences of the communities we serve? Please join me in welcoming Dr. Elizabeth Miller. It's an honor to have her here with us today.
Wow, that was like such a powerful introduction. I'm like a little verklempt here, so bear with me. What an extraordinary honor and privilege it is to be with you all today, to share some bit of my own journey in this work around violence prevention, and to be in a room with many former colleagues as well as new friends, which is really joyful. I just had an extraordinary morning with sitting with many of the learners in this school, and I'm just so filled with immense joy and pride with the kind of next generation of researchers and scholars emerging here. So kudos to all of you, and thank you for the gift of your time today. So I'm going to take you through what feels to me like a different kind of talk, and I felt like you don't need another researchy talk of like, look at all these cool randomized control trials I've done, and because you can go find those and find the papers, and any of you are welcome to follow up with me to think about rigor in our research. But what I thought I'd do today is tell you some stories and share a little bit about my own personal personal journey towards a greater focus on community and structural interventions and co-design with community as one of our pathways forward in what feel like incredibly treacherous and harmful times. So with that, I mean, the title is Healing-Centered Approaches, but with the subtitle of kind of really exploring the science of thriving and resilience as well. And I do receive royalties for writing content for up-to-date about sexual violence and intimate partner violence. So just want to state that up front. And where we're going to go is a little bit of what is this healing-centered engagement about? How might we actually bring that into some of the existing evidence-based literature on resilience, and then conclude with some directions that I've had the privilege of going in recent years around thinking about social and structural interventions in both sort of clinical as well as in community-based settings. And we're going to talk about trauma and violence on so many different levels, and want to begin by saying, you know, as a survivor myself, as well as a person who's been doing research with survivors and on violence prevention and interventions for going on 30 years plus, is a recognition that trauma is super prevalent. And please always assume that there are survivors among us. And as I share some stories with you, just do whatever you need to do to take care of yourselves, including sort of stepping out and just taking some space. And because, you know, what's interesting for me to be giving a Grand Rounds lecture and to disclose my own survivorship was that years ago I was told by my mentors never to share the fact that I was a survivor. And in fact, people would look at me differently, that I couldn't bring objectivity, I couldn't bring rigor to my research, et cetera. And so for the learners in the room, just recognize that there are other ways of being in the world, and that finding a way to knit my own lived experiences with the expertise and wisdom of so many others that I've learned from has been incredibly important, and frankly has been incredibly important for my own healing as well. And that bringing our whole selves into our work is what this is about. And so certainly for the scholars I got to meet with earlier today, continue to hold on to those things that bring you joy. And my hope for each of you is that you will continue to find joy in the work that you have committed to bring, you know, healthier, safer, and more resilient communities together. So my own journey into this work goes way back when I was a medical student, and I was really interested in social influences on health. I was mentored by this guy in Boston who had started the Healthcare for the Homeless program, so very interested in how, you know, social and structural influences were impacting health. And in that context, the med school had just gotten some foundation dollars to support a PhD in the social sciences. So they were like, hey, you, Liz Miller, you seem interested in these sorts of things. How about we pay for the rest of medical school and all of graduate school so you can do your PhD in anthropology? And I couldn't even spell anthropology at the time, right? So it's just like, okay. So I jump into this, and it was through that PhD program that I was introduced to feminist anthropology, to critical theory, to intersectionality, and so forth. And that social theory grounding, I think, has really helped to direct the ways in which I think about public health challenges. In addition, I was born and raised in Japan, so when it came time to do my dissertation research, I went back to Japan, and so went back home, and what I was intending to study was the impact, kind of emerging sort of response, public health response to HIV in Japan. So this is in the early 90s. And as I arrived, the CDC equivalent in Japan, the Japanese Ministry of Health and Welfare, came out with their new public health message, which was the reason there's so much new HIV in Japan is all the foreign women. Like, And thus my dissertation was born. And what they were referring to were young women, primarily adolescents and young adult women, being trafficked from Southeast Asia into Japan's sex industry. And the extent to which this horrific system of sexual slavery was being completely erased by the public health infrastructure, right? And the distance between gender-based violence and discussion about HIV prevention felt like just this huge chasm. And so I wrote a rather polemical dissertation about gender-based violence and HIV in Japan, and returned to write up my dissertation, finish residency. And during that time, I sought out victim service advocates to help me better understand what we were doing around trafficking and other forms of gender-based violence in Japan. And at the time, we still had not gotten sort of violence, and specifically intimate partner violence, much less human trafficking, seen as a healthcare issue, right? So this is like the late 90s, and many of my colleagues in healthcare who were interested in these issues were like, the way to get healthcare providers to pay attention to something is to encourage them to screen. Right? So in the 90s, there was this huge pressure to like, let's get healthcare providers to screen for intimate partner violence. And we spent and obsessed about what the right question was. Do you feel safe in your relationship? Are you afraid in your relationship? Are you being abused? Are you being, hit, hurt, harmed, choked, forced to have sex against your will kinds of questions, right? And at the time, I remember just feeling like the screening paradigm was the way to go. So then fast forward to the year 2000, I'm just finishing my medicine and pediatrics residency training, and I was volunteering one night a week in a clinic that was located in a youth program serving young people who were unhoused. And in came a 15-year-old female-identified young person wanting a pregnancy test. She didn't want to be pregnant. She wasn't using any contraception. And her pregnancy test was negative. And I just assumed that she needed to be educated on her birth control options. And so I started my little lecture with my beautiful, laminated cards, showing her all the birth control options. She's politely nodding her way through this soliloquy. And somewhere along the way, I asked her the adult domestic violence screening question. Do you feel safe in your relationship? And she looked at me, she's like, huh? And I'm like, I don't know, can you get your boyfriend to use condoms? And she's like, sometimes. And I handed her a brown bag full of condoms, and I was like, it's so important to talk to your partner about using condoms every time, and when you're ready to decide what you want to do about birth control, come back and see me. And I'm here every Thursday night. 2 weeks later, I got a call from our emergency room saying, Dr. Miller, we think we have one of your patients here. This young person had sustained a severe head injury, having been pushed down the stairs by her boyfriend. And it was this cataclysmic moment for me, right? Because I'd written a whole dissertation on gender-based violence. I'd spent all this time working on screening for domestic violence in the healthcare setting. I was like, I should know how to do this. It was staring me in the face, and I completely missed it. And so that was year 2000 when I was like, this is what I want to do for research. I want to understand why I missed seeing that. She was in an abusive relationship. What could I have done differently? How might I have approached this differently? And so it's her story that I want to use sort of as our foundation for where I've landed. And because it was really in that moment that I started to question whether the screening paradigm, in fact, was the right way to go. And so in this sort of time, right, this was also the time around when adverse childhood experiences was emerging, the first papers in 1999, right? And a lot of discussion in the ensuing decade about trauma-informed care. And certainly as a clinician scientist, this was, the train around trauma-informed care was, It was zipping really fast. And the paradigm shift at the time was what's wrong with you to being shifted with a trauma-informed care lens to what happened to you, right? Understanding that exposure to trauma, violence can impact behaviors, especially the adolescents I was serving, and the disruptive behaviors that were resulting in them being pushed out of school and incarcerated and so forth. So, and I was like all on the what happened to you bandwagon. What happens with trauma-informed care in the clinical setting, though, is that us clinicians get way too obsessed with the trauma. We want to be informed about the trauma. We want to know, what is it that you experienced, right? And this, like, frankly, obsession about needing to know the what happened to you, resulting in what I think is unfortunately one of the more offensive ways in which this has shown up in healthcare, which is with a 10-item screening checklist, adverse childhood experiences. And you sort of check it and you score yourself. And just for full disclosure, my ACEs score is 6, right? And I don't think that that trauma necessarily defines who I am or the direction, right, that I have been able to carve for myself. And so hearing and over the last decade for me, learning much more about the resilience literature and being with Sean Ginwright, who is an exceptional thinker in the healing-centered space, has really come to understand, right, that even the trauma-informed care paradigm failed to actually recognize our common humanity, and that part of what happened with the trauma-informed care narrative has been this loss of relational healing, but also this kind of loss of seeing people as whole people rather than as broken children and broken families. And so what healing-centered engagement offers is this sort of notion that you exist fully as a person, a whole person in this world, and that you deserve care, love, and safety. And really encourage you all to look up the Future of Healing. It's a very readable blog post that introduces this sort of concept of healing-centered engagement. And it is really kind of, in a nutshell, this sort of paradigmatic shift away from trauma-informed care, but also includes that healing happens in relationships, that it focuses on people's strengths, and is very explicitly social and contextual, and trying to move a lot of the blame away from individuals and families to really thinking about the ways in which culture, spirituality, civic action, and collective healing are part of this work. And I know that sounds uber theoretical right now, but I'm going to give you examples of what that actually looks like in practice. So there's this kind of resilience theory happening, and then, as I'm like an emerging scholar trying to figure out what it was that I missed that evening in clinic, one of my amazing colleagues in Pittsburgh, Judy Chang, did in the mid-2000s one of the most important studies, qualitative study, interviewing survivors of intimate partner violence about how they felt about screening. Right? Nobody had actually bothered to ask survivors, what is it that you want us to do? We just assumed that we needed to screen for intimate partner violence, and that was like, you would screen, case identification, and be done, right? Kind of very much like a pap smear, right? You go do your pap smear, you find the atypical cells, you cut out the atypical cells, and yay, yes, we've prevented cervical cancer, right? And you're like, that actually is not the way in which intimate partner violence works, right? But what Judy, 4 key points. One is stop being so judgy, right? Listen to my story, offer information and support regardless of whether I disclose to you, and do not push me for a disclosure. And probably like the most important, right, piece of this is don't force me to disclose. And what is screening? Screening is, if you say yes, I'm going to give you resources. If you say no, you leave with nothing, right? And so for a moment, we're going to try little audience interaction, and I will kind of repeat what folks are saying. I have never actually had a young person walk into clinic and go, "Hi, Dr. Liz, I'm in an abusive relationship and I need help," ever, right? What are the reasons that a young person might not want to disclose what they're experiencing? They don't want to get in trouble, absolutely. They care about the relationship. Dependent on the other person. Fear of retribution, yep. Normalized, absolutely. May not recognize it themselves, absolutely.
They may not want to go through the reporting system.
Right, exactly. Don't want to get the system involved, right? So all the things, right? And that's exactly it. It's like judgment and stigma, fear of child welfare, and police involvement, not knowing what's going to happen if there's someone controlling them, like what if that person found out, lack of awareness of their rights, and all the things, right? And isn't it amazing how quickly we came up with that, right? And it's just amazing to me how the hegemony of the screening paradigm in medicine has dominated the field, right? And dominated ACEs, our approach to adverse childhood experiences with the screening checklists, continuing to screen for domestic violence. And I'm like, it's the wrong paradigm. And we can all sit here and very quickly come up with a bazillion reasons, right, that people are not going to be excited about disclosing. And so the radical idea was like, what happens if we actually train healthcare providers to say, it doesn't matter what the story is, disclosure and case identification is not the goal. And in fact, we get profoundly low disclosure rates. So within my own healthcare delivery system, they've instituted a new social determinants of health screen. And they were like, "Dr. Miller, our intimate partner violence rate across the health system is less than 1%. And I was like, wow, right? There must be something in the water in Pittsburgh. Come on. So low disclosure rates is obviously not survivor-centered. And the resources are only getting offered, right, to people who say yes, right? And it's an incredibly missed opportunity for prevention education as well. And so Futures Without Violence, which is the national violence prevention organization with whom I've worked for over 2 decades now, said, well, what happens if we define success differently and say that success is measured, right, by actually reducing isolation and increasing options for safety? None of that requires disclosure, right? None of it really, it's I see you as a whole person and I'm offering information to you. And so kind of aligned with that was also wanting to figure out with survivors, with practitioners, how to do this work differently. So I just want to introduce you to the resilience portfolio model, which I hope that a number of you know about already, but if you don't, please kind of bring this into your work, led by my extraordinary colleagues, Sherry Hamby and Vicki Banyard, who've been leading this work around lifting up the science of thriving and resilience for a number of years. And what's very cool about the resilience portfolio model is it's all strength-based and trauma-sensitive, builds on clients' existing assets and strengths. It focuses on well-being after adversity and brings in much more of this healing-centered whole person care. And super cool is this is part of rigorous science, right? They have been building the work with survivors over years to say, well, what goes into supporting resilience? And when we do, what are some of the health outcomes that we see? And so, again, very much situated in rigorous research. And the 4 pillars of resilience that are actually, I think all of us can kind of wrap our hands around, and I know, Anne-Marie, with your work with mindfulness, this is totally resonating, right? Is that there are regulatory strengths, right? So our ability to self-regulate and impulse control, interpersonal strengths, that sense of being in relationship with each other, connected to each other, having social supports, meaning making, that sense of why am I on this earth anyway, right? So meaning making includes spirituality, but your sense of purpose, your hope, your moral beliefs. And then most recently, they've added, with the growing literature on social and structural influences on health, they've added environmental strengths as well. And so these 4 pillars of resilience are actually really helpful in terms of thinking about sort of designing meaningful clinical interventions and community interventions when you're thinking about all of these different domains and touching these different domains. So what does this mean for us clinically? So clinically, I have stopped, so most of my clinical work has been with young people who are incarcerated, unhoused, and who are child welfare system involved. And I was sitting with a young person recently. With every clinical encounter, I'm like, you actually don't have to tell me anything unless you want to, and that your story is really your own. But I really start all clinical encounters just by getting to know you. Tell me about something that you're good at. Tell me about something that brings you joy. And I had one young person who was like, nothing brings me joy. And I was like, it's okay, that's something we can work on together, right? And so as we're going through the clinical encounter, he looks up about halfway through the visit and he goes, do you know what's bringing me joy? And I was like, what? He's like, right now, right? And it was just incredibly powerful, right, as a clinician, to know that by taking this kind of strength-based and resilience-focused, I mean, the whole conversation is not all the things that you've done wrong and everything about what you're doing right? And it was really just like so important to understand how bringing this kind of framework into the clinical encounter completely transforms, right, the way in which I do my work. And it's also encouraged getting young people to do art and journaling and other ways of storytelling as part of this healing process, as well as helping identify important adults in their life so that we can improve and strengthen those social supports. And what's fun about being in Pittsburgh is it's a small enough community, and I tend to do a lot of community work, so I know many folks in different schools. And one young person, I said, who is like an important adult who really cares about you? And he actually identified one of the community health workers in a school who I happen to know. So that afternoon, I was like, I'm not going to tell you who said it, and I just need you to know that your loving on this young person had such a huge impact, right? And being able to just nurture those kinds of amazing adult mentors who are there to support our young people. And so there are lots and lots of different ways to do this clinically. But what this also helped me understand was the development then of a universal education approach. So this was designed with survivors, with practitioners, with advocates, where once we understood that disclosure was no longer the goal, we were like, really, we ought to offer information in every clinical encounter. And so the design of these, and you'll see them on the Futures Without Violence website, but they're like palm-sized brochures that fold out with information about healthy relationships and unhealthy relationships, and how to help a friend, where to get resources, how to call a hotline, etc. And each one of these has been designed with young people or with people. We've worked with a number of tribal communities to design one that's much more relevant for use within clinical settings there. In tribal communities, working with LGBTQIA+ individuals and advocates, etc. And so the intervention part that we have trained healthcare providers on is called CUES, right? It's a nice little mnemonic for health providers. C, confidentiality, don't have these conversations with other people in the room. Do the universal education, right? Offer the information, but the other extra piece of this is to say, this may not actually be relevant for you. and I suspect you know somebody, right, who can use this information. I really need you to take this information along so that it will help, so you can help others. With that, I have had numerous young people say, can I take several of those cards with me, right, because I know exactly who could use this. And so that empowerment piece of like, I want you to share this information with others is incredibly important and is touching that resiliency piece of connectedness to others. And then finally, the S of support, which is if somebody, what happens, right, is you take this strength-based approach, young people then kind of lean in and they're like, I feel like I could tell you everything. And I'm like, please don't. But it turns out when you take a universal education approach that there tends to be, and our studies have shown, more disclosure. And so be prepared when somebody says, this is what's going on, to really figure out how we do those options for safety. And that requires knowing who in your community are the supports, who the adults, mentors are, who the victim service advocates are. It's incumbent on us to actually build that community of support. And we've been really mindful working with young people about language, right? So when we talk about adversity, it's inclusive, right, of parents, caregivers, other adults, partners. So we just talk about it in this like educational pamphlet as complicated relationships, right? Relationships can be complicated. And to really kind of keep that space open. And that we really think about adverse childhood experiences as a conversation. Like sometimes these things happen and not can you score yourself, right, on a checklist. And as what we have found in numerous randomized trials now is that universal education increases your knowledge of resources, your confidence to use those resources, your connectedness and trust of the healthcare delivery system, and it does, as I'd noted earlier, does end up increasing disclosure. So even though disclosure is not the goal, right, by taking a more healing-centered approach, it is really, we're demonstrating that this seems to be a much more palatable way for healthcare providers to do the work. And we're also finding that what we're doing is tapping into the power of altruism by encouraging our patients, our clients, to take information to help somebody else. So we've had amazing stories about people coming back to clinic to get more of the information. And in my research studies, we've asked folks, like, what do you do with the information? And one woman was like, I keep one in my bedroom dresser drawer, I keep one in my wallet, and I shared one with my mom because she needs it more than I do, right? So this, really sense that universal education is a way to promote health equity, and I'm just going to keep kind of moving through here in terms of the interest of time, but also I think it's a way to help providers provide healing-centered care and help healthcare providers get back to our origins of wanting to be healers in the first place, right? And like being allowed this like brief intervention, it takes 10 or 15 seconds to offer universal education. And on the provider end, they feel like they're doing so much more around prevention and in helping patients know that those supports are available. So, yay me, right? We've done the RCTs, yay, we've demonstrated universal education works in the clinical setting. The challenge with, and the bringing in a strength-based approach, totally doable, but the challenge is that's like one small setting, right? It's the focus is on clinical encounters, and what are we doing really with the big challenge, which is our silos, our healthcare delivery system over here, educational system over here, social services here, child welfare there, juvenile probation there, and this challenge of siloing. And one of the things that we have found in our healthcare work is most healthcare systems have no idea who their victim service advocates are, much less like, do they have a partnership with the food bank, right? So they're screening for social determinants of health, but then have no idea what to do other than hand people, here's the number for the food bank, right? No sense of like how to actually make a warm referral. And so Getting back to healing-centered engagement, here's another reading recommendation, the work of Page and Woodland, Erica Woodland, is really thinking about sort of healing in a much, much more collective way. And one of the things that I want to argue is that in our work in public health, building those cross-sector partnerships to build stronger and more resilient communities is part of the way, in one of the pathways forward. Is like, it's like how many of us, right, as I was talking about siloing, I saw a lot of nodding, right? What we have to figure out is and be able to articulate that siloing is intentional. It's a way in which power is maintained. And one of the things that we can do in public health, because we do think about health much more holistically, is bring a healing justice frame into our work. So what does that kind of look like in practice? So one of the projects that I got to do with HRSA and Department of Health and Human Services was building health center and advocacy, victim service advocacy partnerships to better support survivors. And what we were sort of emphasizing is that in the context of intimate partner violence, actually receiving health care gets really challenging, right? Abusive partners will prevent partners from their partner from even getting to a clinical appointment, in addition to all of the physical and emotional health consequences of experiencing intimate partner violence. And so we were helping health centers understand they don't have to do all of this, and that victim service advocates are there to actually do the work with them if they would actually allow those partnerships to happen. And so this was a DHHS supported project with Family and Youth Services Bureau and HRSA to actually create state coalitions. So this was like super cool for me in that I'd always been sort of in that sort of clinical and community health space, and to actually start working at the state level around coalition building. And this was bringing together primary care, public health, and domestic violence and sexual violence coalitions. So state coalitions who did not actually have any kind of relationship with each other, right? And we're like, wow, how do we say we should do this at the local level if we're not doing it at the state level? And so that was the state and territory leadership teams, and nurturing these teams to then work with local health centers, local domestic violence agencies to actually firm up these partnerships. And the demonstration sites then were doing what we call closed loop referrals, right? So like you're in clinic, you have somebody who needs support, you're immediately able to like call somebody within the victim service agency to get support for that survivor if that's what they want. But simultaneously, survivors coming into shelter, coming into care to victim service agencies have often not gotten health care. And so how do we actually have a golden ticket so that when that victim service agency calls the clinic, they're like, I have a client who needs care, that golden ticket gets them in for care right away, right? So closed loop referral is not just here, you can call this agency. It is really, truly, we are working together to support this person. And it is not easy work, right? But what we did with the state coalitions was demonstrating that. So cross-sector collaboration is a sort of example of another example of how this can be done is some work that I've had the privilege of doing now with the American Academy of Pediatrics, and supported also by HRSA. And this is a new National Center for Adolescent and Young Adult Health and Well-Being. The focus of this entire center is getting people to integrate systems, right? And so, can we actually insist that for any young person, whether they walk into a library, they walk into a clinic, they're at school, they're in an after-school program, no matter what door that young person gets connected to all of the available resources and services. So it's just a simple way of saying no wrong door, right, is systems integration. And so I have the privilege of actually chairing the National Coordinating Committee for this center, and have really come to appreciate the extent to which systems integration becomes a pathway for doing really equitable work, right? And making sure that no young person, no child, no family gets left behind. And so I'm very excited because we've designed a toolkit with young people and with advocates and practitioners that will be online very, very soon. I'm hoping by the end of the year, and available for folks to go, what is this systems integration thing? How do you actually do partnership agreements? How do you actually set things up so that it really does feel like a seamless, no wrong door for a young person? So the definition, our operating definition, is this coordinated multi-sectoral approach that aligns healthcare, education, and community resources to meet all youth and young adults where they are and address the diverse needs of youth and young adults. So I'm super excited that we're being able to operationalize kind of the science of what we've been thinking about in terms of resilience and the importance of cross-sector collaboration, and now put this into practice through a systems integration toolkit. And embedded in that is a commitment to inclusion, right? No young person left behind, and how we do that. So I am going to conclude. And Anne-Marie, how much time do I have left? Oh, perfect. Okay, good. Just wanted to make sure, because I looked at the timing and I'm like, oh, I can't tell. So in conclusion, wanted to share one of the things that has brought me an immense amount of joy working in Pittsburgh, which has been the ease with which community partnerships have been, that we've been able to just nurture and grow. And back in 2018, my boss at UPMC Children's Hospital, so the department chair of pediatrics, was like, Liz, I want to do something big. I want to have a legacy. I want to do some kind of study on child thriving. And in June of 2018, he kind of rolled out this plan for a longitudinal study of children from birth to adolescence. And the feedback from community members was, we are so sick and tired of being studied, and we've been studied and studied and surveyed, and nothing has ever come of this. And in fact, one community member was like, this just feels like white scientists going after black baby DNA. And so I shared that with my boss, and he's like, well, that's not acceptable. We need to do something different. But he's an infectious disease, like a virologist. And he's like, I want to do something. We've got some Catalyst funding, but we need to do it with community. And so, Liz, will you take this on? And I had an amazing partner in this work, Val Chavis, who is a community leader and working in one of our family support centers. And she had actually educated a number of my students in public health and nursing and social work and medicine about the impact of racism on health and how it impacted her and her family. And so Val, and I was like, Val, do you want to do this with me? And she's like, sure. So she and I co-led the start of this. And what was so powerful is Val was like, what do you all scientists mean by thriving? Because what thriving looks like for me in my neighborhood is so profoundly different, I think, from where you all are. And so what we ended up being able to do was turn this Pittsburgh study into a community-partnered research effort to actually study thriving and resilience together. And so our commitment is to thriving children and racial equity. And the vision is a wonderfully audacious one, that every child in our region is healthy, thriving, and achieving their academic goals. And here too, listening to community members, initially the vision was, and graduating high school on time. And many community members were like, that's awfully ableist, right? That's not what every child is, that doesn't make sense. And let's be more let's be more like mindful about what inclusion can look like. And so achieving their academic goals. But it's an invitation to community members to actually join us in the science and doing science together. And the challenge here is to do collective impact work, because there's phenomenally just within this school alone, phenomenal work happening. How do you actually kind of all row in the same direction? How do you do collective impact work? And I have to say, I still don't think we've figured it all out, and it's really hard, and we have no choice, right? We have to be doing more work collaboratively and doing work collectively. So it is community-partnered research, but it is also unabashedly translating research for policy and practice. And we invite community members to participate on scientific teams, but with a very clear focus on undoing systemic racism and thinking about translating research always for policy and practice. And back in 2018, we came up with our shared principles, and those of you who do community-partnered research will recognize many of the principles, and that's a little bit small to read, but it says number 4, which is my favorite, which is developing research with people and not on people, right? And then number 10, which is leave your ego at the door. And then lots of things in between, which include transparency around data, returning data to participants in communities, having ongoing communication, and being in there for the long haul. And we have stuck with these shared principles. Every time we come back to it, our community members are like, yep, that's what we're doing, and we actually evaluate what we're doing in our science based on these items. And going back to Val and her sort of idea around thriving, we actually did concept mapping with numerous community partners around what does thriving look like, and have really expanded the way in which we measure thriving, not only at that individual level, but thinking about things like, are we measuring fun and happiness? Are we thinking about family relationships and caring families? Are we thinking about clean air and clean water, healthy environments, et cetera? And so it's just been a really wonderful conceptual framework that we've then been able to bring into our research. And there's more about the Pittsburgh study in various publications, but has been very much around system alignment and trying to bring a transformative justice lens into our work. We have scientific collaboratives at every developmental stage, from pregnancy through adolescence, as well as cross-cutting collaboratives like a data justice collaborative that focuses on increasing data literacy among community members. So understanding where data come from, how we use data, how we interpret data as one mechanism to increase collective efficacy. And most recently, we started doing this with young people, and it is so fun to actually review things like the youth risk behavior survey data that we do in our county with young people and say, what does this mean to you? And how do we analyze these data together? And a health services group, a school, Healthy and Thriving Schools group, environmental justice group, as well as one focused on policy in place, so neighborhood level transformation. And I will conclude with just one example of this. All of the interventions that we are evaluating are co-created with community partners. And this one, Creating Peace, is a racial and gender justice focused curriculum that we actually brought from the Democratic Republic of Congo and have adapted and modified with young people and with advocates in our community to really be one that makes sense for our young people. And it is kind of why, right? We realized that we couldn't discuss anti-violence work without also addressing systemic racism, and we needed to really create space for young people to be able to talk about racial and gender justice in kind of safe and supportive ways. And there are specific aims for this study. Like we're actually just finishing up. We have just a handful of final surveys to collect this month, but are focused on things like decreasing weapon carrying, decreasing involvement in recent use of violence, and so forth. And it was funded by the National Institutes of Health. And I just leave you with this quote from a young person who said, "I think every young person needs a space like Creating Peace. It's changed the way I've looked at things. Even when I talk to my friends, before we used to talk about celebrities or whatever, but now I know how to talk to them about the news and stuff, like, hey, how do you feel about this? What do you think we can do about this?" And that, bringing young people kind of into this space, encouraging their skills in activism, and what we're actually starting to see in our data is super exciting. And so lots and lots and lots of support, mixture of federal and foundation funding to make this work happen. And I'm just delighted to have a chance to share it with you. So thank you, and I hope I left some time for questions.
Thank you so much. First of all, Liz for president. Of all the things, everything. So many questions and comments, and but I guess one thing, I just thank you for your advocacy on the realities of screening. Unfortunately, we still, despite so many pieces that have been written, we still don't have consensus in the field, and there's still so much emphasis on screening. So I guess that's kind of where I want to land my question on is what are your thoughts on what more we could do to make some shifts at a systems level and policy level to really address why IPV screening doesn't work, why ACEs screening doesn't work, how can we talk to California about their ridiculous laws, and all of that. So yeah, any insights on that?
Yeah, no, it's interesting, and interesting that I think the narrative is starting to shift in California too, which may actually be our pathway too, right? Of saying, we actually tried it, this is what we've learned, not so much, and we'd like to take a more relational and healing-centered approach. So I am kind of continuing to stay on top of where things are in California and what we're learning. It does help that my spouse is one of the evaluators. Full disclosure, right? And so it's just been really right, but it's so screening, right? Like screening for depression, it's screening, and there's certain things like depression where it actually makes sense because you're asking about symptoms, right? Are you having, continuous worry, et cetera, right? And you're treating symptoms. Whereas the ACEs screening, the domestic violence screening, are not about symptoms. They're situational, and no matter what, ends up putting the blame back on survivors and the onus back on survivors to fix the situation, right? And so, it's just helping people understand that the complexity of the ways in which people experience trauma and violence in their lives is not the same thing as helping manage symptoms. I take care of incarcerated young people. I guarantee every single one of those young people has post-traumatic stress symptoms that we're managing. I ask about those symptoms. I don't actually need to know how many loved ones they've lost to murder, right? And so I am hopeful that that there are enough shifts happening around the ACEs aware work in California that will hopefully lead the way. There are numerous other state coalitions, though, that are trying to take on much more of this healing-centered approach. And then most importantly for children, the American Academy of Pediatrics has come out very strongly against ACEs screening. So I think I'm seeing these glimmers of okay, now we can start to knit it together to say we can actually take a more healing-centered approach here. And frankly, practitioners and healthcare providers, family members are much more happy to talk about healing and recovery than like all the badness that's happened, right? And none of us are sitting here like trying to erase or negate, right? Like it's so important to understand that trauma has happened, but at the same time, we have to be able to chart a better pathway forward. Yeah.
Kind of build off of that a little bit. So what advice do you have in the research context for thinking about, asking some of these sensitive questions? There are times where you had the statistic, like 17% of women who experience intimate partner violence don't seek medical care, something like that. But we need to know that 17% sometimes. And I'm hearing the message about disclosure isn't the goal, but how do we as researchers then take on that advice and ask the right questions or get the right information?
No, I love that question. I'm going to answer it twofold. One is around going back to the ACEs research, and then kind of the ways in which we're doing research with survivors. So the ACEs research, Vince Feli's work, 1999 paper, for those of us who were doing violence-related work, it was a profoundly important paper, right? Because remember, I told you in the 90s, trying to prove that exposure to violence is bad for people's health, right? Can you imagine, right? But it was a landmark study, incredibly important, right? The challenge was then they took those 10 survey questions, put them on a checklist and said, now we have an evidence-based screening tool. And I'm like, it is not an evidence-based screening tool. You've never actually evaluated this in an intervention study. Like, no, and we, to this day, don't actually know the sensitivity or specificity of this screening tool, right? So be mindful, right, that both things can be true. Incredibly important to document the research and the prevalence and so forth, and so much of my work has been in that space too, and that we really think about translating policy, like translating for policy and practice when we do meaningful research and practice partnerships, right? Like there was not an advocate in the room to say, this is not a good idea, right? And so that was where things like really slipped. The other is that you can do both things. You can actually do work with survivors to like design the way in which you ask these questions. No survivor will say, oh, don't do research on that, right? There's very much this sense of documenting what happened, documenting the reality of what so many survivors experience is incredibly important. But we do things like, even like interviewing a survivor, we will start by actually giving them the gift card before we even start the interview, right? It's a small thing, but it's like you showed up to do this interview. For that, we are immensely grateful, and you have absolute control about how this goes. And if 3 minutes into it, you want to stop, that's totally fine, right? And so there are ways in which we do our research that can be much safer, much more supportive, much more survivor-centered, and that resources are provided at the start, resources are provided in between, that we figure out when we say the next series of questions are going to ask about some difficult things, you can skip through them if you don't want to answer them, and so on and so forth, right? So there's ways to do good ethical research around trauma, but also the more that we co-design with practitioners and survivors, the better the work. I mean, every study I'm working now with, my team is leading a disability justice research collaborative, and it is mind-blowing to me all of the ways in which I'm like, well, we should have been doing that, we should have been doing that, right, to improve accessibility. And so there's just this continuous learning for me. Earlier, the students were asking me about, like, how do you continue to do the work like this? And it really is this vicarious resilience, right? Because it's like learning from survivors, learning from people with disabilities about how to actually do this work better. That is like, I'm like, okay, we have to do this. You know, like it's so much more rich. And so, you know, I think that we have to and cannot give up the importance of documenting, right, the realities both quantitatively and qualitatively, and simultaneously be able to design our studies, our data collection methods in ways that are not harmful.
Wonderful talk, Liz.
Thank you.
My question is more about the partnerships like that you have with the survivors and in the co-design of these interventions and approaches that you're doing. I'd love to hear more about that process of like how you engage them throughout the whole, the whole shebang, really.
Yeah, yeah.
So if you could talk more about that, because
Indeed. So we have in Pittsburgh an intimate partner violence, sexual violence collaborative that has been going on from it started as I was moving to Pittsburgh, and sometimes the universe works in kind of amazing ways in that had just been awarded an R01 to do work in California on reproductive coercion and reproductive coercion interventions. And I had just accepted the job in Pittsburgh. I get a call from State Family Planning in California saying, Liz, we're so excited. We've just disseminated all the intervention materials to every family planning provider in the state. And I'm like, did you forget that we just got this randomized trial? I'm like, lovely that we've disseminated, and we actually haven't done the RCT yet. And by the way, I need to move to Pittsburgh, and it was like the whole thing. But I knew nobody. And then 2 days later, email comes through, Dr. Miller, we just came across your research in reproductive coercion and adolescent pregnancy, and we're not able to access any of the publications. Could you send those to us? It's a foundation in Pittsburgh. And I started crying because I'm like, this couldn't possibly be true. But I'm like, here are the papers. And by the way, I'm moving to Pittsburgh. I know nobody. And I have to move this $2.5 million randomized trial to Pennsylvania. And within 3 weeks, the CEO there had organized a community meeting with advocates and family planning providers and so forth. I flew into Pittsburgh, so presented what it was that we were doing, and again, the idea of wanting to co-design things together. And within a week, I had all the letters of support I needed to transfer the grant from California to Pennsylvania. It was crazy. So sometimes you just let the universe take care of you, right? But why is that relevant? It's relevant because that collaborative is still together. The people have come and gone, but the commitment to a research practice partnership has been now in existence for 15 years. And what's beautiful is that many other scholars in IPV and sexual violence are part of that collaborative too. So it's no longer like the Miller Lab, but it's much broader. And the way in which we do some of the design sessions have been using human-centered design techniques, but most of it on Zoom, which we've learned to do post-COVID, right? And so a lot of different human-centered design activities. And one of my team members actually just presented on this, the importance of bringing joy practice into the work too. And so there's relationship building that happens even in these Zoom sessions where everybody's sharing things about what's bringing them joy today. And but in those relationships, then even in an online community, they're able to trust each other a little bit more and share a little bit more so that we can actually keep working on the design. Because what we're working on is alcohol-facilitated sexual violence interventions that are much more mindful about the experiences of students with disability, right? And so it's wonderful watching my team just kind of lead these efforts.
Well, thank you everybody for being here today, and to Dr. Liz Miller.
Thank you.
So wonderful having you. Thank you all.
Thank you.